You're listening to the Primary Care PT podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. Stay tuned and subscribe. Okay, hi y'all. I know I have been very inconsistent with my, I'm trying to get these out every 2 weeks, but it's really just not, I just can't. So they come out when they come out, and y'all can listen when you can listen. And so today, I'm actually recording 3 podcasts today, and I already did one and it was so good. And I feel like this one's going to be even better. And the last one's going to be fire. So today I have, Dr. Seth Peterson, Dr. Jess Klain. We're going to be talking about Cauda Equina, low back pain with leg pain, and Cauda Equina syndrome, which if you're a PT student, like when I was a PT student, you might be thinking Cauda Equina, like, ooh, which, you should be thinking that way to a certain degree, but we have to understand that a lot of different health conditions exist on a spectrum, and Cauda Equina is no different, especially in our aging population. So Seth, why don't you go ahead and tell everybody a little bit about yourself, and then we can jump in and talk about this lovely case report that you wrote up for JOSPT cases. I don't know, was it last year or something like that?
Something like that. Yeah.
Something like that.
I think it was,
Okay.
I think it was maybe earlier this year that it came out.
Okay.
It's been a long year.
Yeah, it's been a long year. It has. But yeah, tell everybody a little bit about who you are and where you come from. And you've been on my podcast once before, so.
I have, yeah. I get to, I don't know how many people you've had on more than once, but I get to be one of them.
You sure do.
I'm a clinician. I'm a physical therapist down in Tucson. So I have my own private practice. It's kind of an orthopedic practice, but we see a lot of patients with spinal pain. I think like most people in the US, well, even if you have like a sports clinic and you know, are marketing for people in the local high schools, you probably see a lot of older adults. That's just the population in the US right now. So we see a lot of those too. We're kind of surrounded by a few active older adult communities. So we see a lot of pickleballers. That's like a popular thing now. Pickleball is fun, but I haven't played in a little bit.
I love pickle. Have you played? I love pickleball.
I have. It's been a little while, but I need to get out there. We're building like 11 pickleball courts at the nearby park. So I'm going to need to hit that up. It's going to be great.
Cool. Pickleballers.
Yeah. In downtown Tucson, which has had like, you know, if you've been to Tucson 20 years ago, you haven't experienced this, but the downtown has been like revitalized, and there's a bar / pickleball court, which is pretty cool. It takes up like a whole block in our downtown area.
I love that. So, I'm gonna have to visit sometime. My grad school roommate went to University of Arizona, so she talks about Tucson. Maybe I'll have to set up a date with her to come out there and play a lot of pickleball.
Yeah, and hey, our basketball team's #1 right now.
Oh,
it's the kiss of death, but
good to know.
Took my kids for the first time last weekend.
So how'd that go?
It went well. I mean, my kids are 7 and 4, so the 7-year-old could follow it. He liked it. We got to see Arizona crush Colgate.
Oh, nice.
But the 4-year-old, I think, was just there for the popcorn and the cheerleaders, to watch the things that they could do, the flipping and the splits, and he was in awe.
Oh, that's cool.
So, yeah, so this is a patient that, in terms of the case, that I'd actually seen this guy before, but he came in with a different presentation this time. And, you know, I don't know if you want me to go right into it.
Yeah. I mean, so this is, well, first of all, this is a paper that is published in JOSPT cases. So if you are not familiar with how that works, you do have to have a separate subscription to JOSPT cases. Even my Tufts library access is not subscribed to it. So unfortunately, it's not open access to everybody, but you can send Seth an email and I think he can provide access to you if you want to take a look at it. But yeah, it's a go. So yeah, go ahead and introduce the case.
Well, and we also, I mean, if you do, you know, gain access to this, it's kind of nice. And I think JOSPT cases is doing a really good job with this. There's some supplementary materials. There's some videos of how I treated this guy, and there's a lot of tables and figures that kind of demonstrate the clinical reasoning that went into this case, which I think if you're suspecting Cauda Equina syndrome, you should have, your clinical reasoning should be on point to be making decisions. So yeah, I mean, so this was this was a guy who, let me kind of pull up the figure here. So he came in and he had back pain, and I know, and he had a diagnosis already of spinal stenosis, but he had radiating leg symptoms. He had symptoms that went down to both feet, down the back of both legs, and then he did have a change in what he called a change in sensation in kind of his saddle area. Um, so yeah, so he was an older guy. He was a retired physician, so that gives you an idea. Maybe not the average patient in terms of educational level, but he was a dermatologist. He was a
Yep.
retired dermatologist, so maybe he wasn't the most knowledgeable on musculoskeletal issues. So yeah, so he came in with these symptoms. He had reduced walking distance, so kind of like a spinal stenosis sort of presentation that you might see. His symptoms went away when he was seated, and his symptoms came on as he was walking. So there was a relatively mechanical kind of presentation that he had.
Okay. Yeah. So, what was, so you'd seen this patient before. What was different about this time that he came in?
Yeah, and I guess so. He's 78-year-old, so imagine that. Relatively thin, so body BMI was 20.6 as I'm looking at it, and he described it as burning, and then had this saddle paresthesia that included the penis and scrotum. It was present about 20% of the day, so I found that spot, and he was limited to about 4 blocks. He could do 12 blocks before, so that was reduced. Yeah, so in the past when I'd seen him, I mean, he had some of, in terms of leg symptoms, he had some of this present, but I was seeing him more for balance and issues related to that. So he was doing okay managing these symptoms, and they had gotten worse. So, he'd had these symptoms for 10 years. The saddle kind of paresthesia was new. That was present for about 18 months. And at that point, he had been having a worsening in terms of his leg symptoms. They got more severe. And again, his walking distance kind of dropped down from 12 blocks to this 4 blocks.
Okay.
He had, I kind of mentioned the spinal stenosis diagnosis that he had. Again, that's, he had both the clinical presentation you can see, but then also the radiographic diagnosis. So throughout his spine, he also had a small grade 1 anterolisthesis at L5 and S1.
Okay.
So this is Jess Klain. I am a PT in Denver, also working in orthopedics, but seeing a wide range from teenagers, recreational athletes, competitive athletes, and certainly get a decent amount of older adults that want to be active, are limited in being active. So like Seth, I have seen similar presentations to this before. And my question to you, Seth, is when this gentleman walked in, were you concerned? Like on a scale of 0 to 10, how concerned were you for these yellow flags, red flags, or, put him in an ambulance ASAP to get him to the hospital?
Yeah, I think that's a good question. When you're developing, and this is great from, this red flag, the international framework for red flags that IFOMT developed a few years back. Laura Finucane was the lead author on it, but it kind of came up with this concept of, well, how do you develop your like level of concern.
Yep.
This patient? So that factored in, right? I mean, so one of the things that is key, I think, with something like this is the urgency. So you're coming up with, when you think about action, what are you going to do? What's the urgency? So the fact that he'd had it for 18 months, it's not like tomorrow, all of a sudden, it's going to you don't have evidence to suggest that tomorrow it's going to dramatically worsen, or over the weekend it's going to dramatically worsen. Versus if you have this acute Cauda Equina presentation where, someone, usually in the cases that have been reported, it's a younger person, and the symptoms come on quickly, that is potentially a situation where urgency is a lot higher. And I think those are the cases when people think of Cauda Equina syndrome, they think of those sorts of cases.
Mhm.
But, there was a great paper, the lead author was Christine Comer, that was called Shades of Gray, and it used this grumbling Cauda Equina symptoms in older adults with spinal stenosis was what the paper talked about. These kind of and I love that word, like these grumbling CES symptoms. And that, I think, was what this individual had. So in terms of my concern, obviously, when someone has symptoms like this, the bilateral leg symptoms, those are the most common symptoms in people with CES. And then next is changes in urinary function, saddle, sensory changes in the saddle area. My concern was high, but I don't think that the urgency was high. And I think those things get conflated, I think, in clinicians' minds. And so I think this was a situation where obviously you need to watch this guy like a hawk. You need to be on those symptoms that he has that are consistent with that grumbling CES sort of pattern. But it's not necessarily a situation where you'd get a lot out of referring this guy to, like, the emergency department, given that he's had them for 18 months, if that makes sense.
It absolutely makes sense. And so to follow up with that, how we communicate the concern to the patient, but not worry the patient or create unnecessary anxiety or alarm in the patient, that has a lot to do with our relationship with the patient and how that patient personality presents to us. But how did you communicate with this patient that this is concerning, but also not completely alarming where he's going to lose total function of his legs tomorrow?
Okay, can I stop everybody right here? I'm going to write that down because we need to get to that question. But before we get to that question, I almost want to go back to what were some of the features of his clinical presentation, that of this specific case of his clinical presentation that led you to determine your level of concern and the urgency in which it should be pursued. So as you're going through this clinical exam, what are the features? Because I even wrote some of the things down, but I wanted to ask you first, what are some of the features that you're assessing, not only from a differential diagnosis perspective, but some of the other features that would make you more or less concerned? And then we can come back to how we're communicating this to the patient.
Yeah, I mean, one big thing was that his symptoms also. So I mentioned he's, obviously the timeline. He's had them for 18 months. They've come on, they're new over that period of time, but that's a relatively long period of time, right? So that's important. He's already had imaging. And then the other thing is that it's been this gradual progression, but maybe a key thing is that his symptoms were intermittent. So he could sit down and they would go away. So that's another thing, like, okay, so it's not constant. Additionally, so when that came up, asking him, additional questions about, have there been changes in sexual function, have been there in urinary functions? So with Cauda Equina, a good way to think of it is asking, when you're asking about urinary function, to ask about frequency, flow, and sensation, the FFS acronym, to get into that. And he denied any of those. So, and bowel changes, he hadn't had any of those. So those, when you think about like this, the complete CES, that stage 4, like, more, this is the nerves are not functioning situation. He wasn't there. He could sit down and it would come back. So it was like a maybe stage 1 or stage 2. And that was also progressing gradually, and he could sit down and the symptoms would go away. So I think all that together kind of, I think, factored into this.
Gotcha. So I have acuity, the lack of acuity in this circumstance, the fact that it was more chronic, existed over a period of 18 months, sort of gradually got worse, the intermittent symptoms. And then one other thing that I wrote down from the case description or the physical exam description was that his myotomes tested out. Basically, all upper extremity and lower extremity. He wasn't actively having any significant weakness. At least that's what I gathered. I'm not the best reader. I'm not gonna lie. So if I got that wrong, let me know. But the cases where I would be more concerned about where this guy was at, because sometimes, even I feel like I'm semi-educated, and I feel like when I'm telling stories about myself and my own problems, I do a terrible job because I second guess myself. So sometimes even healthcare providers are like, we make the worst patients, right? So even though this guy was a retired dermatologist, we still have to put on our critical thinking and our good, patient communication hats, and make sure that we're explaining everything and asking the right questions. But anyway, coming back to the fact that he didn't have any significant weakness makes me a little bit less concerned. That's telling, and the fact that it's going away when he's sitting, going away when he flexes forward, that's telling me that this nerve is getting, or these nerves are at least getting some intermittent relief, and there's not any significant progression that's going to lead to something that's more permanent, which is what we're concerned about with Cauda equina, right? We're concerned about permanent loss of function. And that's why it is considered, a quote unquote red flag condition, because if it's there and it's bad enough, it can cause permanent loss of function. So was there anything else in that you gathered from this case or from other cases, or just from cases that you've seen, that would lead you to believe that this was a more urgent case?
Yeah, I mean, and just to piggyback off one thing, I think when I talk to people about CES, they conceptualizing it sometimes is different, and it was earlier in my own career, right? So if you think of like foot drop, which most PTs and orthopedics have seen, there's a timeline for that too. We know that if it doesn't make any progress in the first month or so, then you have a lower chance that it's going to come back, and that gets worse to the point where after 6 months, it's, if you have surgery, there's virtually it's guaranteed it's not going to come back. And the other thing is if it's very weak. So if there's been a huge impact in the function, the odds are pretty low, even if you had surgery then, that surgery would be that successful in terms of an outcome. And it's the same thing with CES. It's just that the nerves go to different things. They're not the foot, right? So, and if you don't get your tibialis anterior to come back, you can put a brace on. But if you don't have the ability to, urinate on your own, yeah, I mean, it's totally different. Having to self-catheterize the rest of your life is a bigger consequence than just being able to strap a brace on and you're good to go. So, yeah. And what was your question? I wanted to add that.
I don't remember.
Katie was asking about
Jess always remembers what I don't remember.
Clinical presentations of CES that we've seen in the clinic. And to go back to something Katie said at the very beginning of this, when I was in school 15 years ago, we spent a lot of time on Cauda equina. Like, it is definitively etched in my brain, everything we learned about it. And I think that's great. I have never in the last 15 years seen an acute CES person present to my clinic where I was the one making the decision to say, I am really concerned that you have Cauda equina syndrome, and I'm the one that needs to make the decision to do this. I would hope that most people in that acute Cauda equina syndrome presentation wouldn't come to PT. I would like to think that urgent care or the ER or their primary care physician would be their first stop, because in an acute CES scenario, those symptoms are very alarming, and they should be alarming to people. So I think it's interesting how much time I spent learning about it in school from this acute red flag situation, and I've never seen it in the clinic. But my line of questioning for all my low back patients the first 5 to 7 years out of school was, okay, urinary retention, urinary frequency, all those red flags that got a little confusing for patients who maybe had pelvic floor issues, or maybe we're older and it wasn't a Cauda Equina thing. It was a prostate thing. And
Right.
then
Which
you kind of
this
get off
case,
track.
yeah, and
really
this case
quickly.
actually had some of that, right? Like he had BPH, and that was mentioned in there, and maybe he was thinking that was the reason for some of those perineal symptoms.
Right. So typically I've seen a lot more of patients like Seth's patient, his dermatologist named Adam, where it is an older person. It has come on gradually. Is it Cauda Equina? Is it stenosis? And there's a lot of overlap between those two because stenosis causes Cauda Equina.
Mhm.
Um, and presenting in such a way where it's not those red flag alarms. It's how are we going to approach this and help this person feel better and function better?
Mhm. So I guess my next questions for Seth would be, if we're talking to when we're teaching people about whether it's entry level DPT or new grads or post professional education, when we're teaching people about clinical decision making when it comes to low back pain with leg pain, and all of these other features that come along with it, how are we teaching them about the management of it and the differentiating factors that mean, hey, this type of case needs to go to the emergency department. This type of case needs to be or could potentially be managed conservatively. So let's talk a little bit more about the management, the early management decision making, and then we can talk about how we are communicating that with the patient.
Yeah, I mean, I think there's a lot that you could go, and I think that's why I kind of wanted to write this case, is because there's a lot of interesting new things. I mean, the UK came up with a pathway for suspected Cauda Equina syndrome, and they have it where the new symptoms are kind of the key concern for them. Bilateral leg pain, again, is kind of so sudden onset. So again, the newness, the suddenness, they talk about that a lot. So that being urgency, factoring into the urgency, but having this new onset difficulty initiating urination or difference in flow. So knowing, I guess, to answer your question, Katie, it's to know why you're asking the questions. If you're like me, like when you were in PT school or even in residency, I don't know that even the instructors maybe understood exactly what you were looking for. I was just taught to say, have there been any changes in bowel and bladder function?
Right.
And
Yes.
it's
Yeah.
like, well, I guess that covers some of this like newness thing, but um, there's it's in a way it's a little bit of like I always looked at it as like, let me just rattle it off, and they're going to say no, and then I can move on. And sometimes I think you can see people hesitate, like when they have BPH or they have changes that where they have, and then they say no. And so I know, or I might know already ahead of time, that they have that. I mean, so to ask specific questions, asking more specific questions. So alluding to that, for, asking about sensory changes, where are the sensory changes, like the saddle area specifically, and kind of mapping that out on your body. That's what you're looking for.
Mhm.
Making sure if someone has radiating pain in one leg that you do clear the other leg. You ask them specifically about the other leg, because sometimes patients won't mention it because to them, they have this really, really bad pain in the right leg and they just have this tightness in their hamstring on the left leg. That's not a big deal. It's not related in their mind. Well,
Mhm.
you need to ask about that because that's probably, or it could very likely be related to
Like,
a
yeah, that
lumbar condition.
neurogenic tone. Yeah. Yeah.
So asking about those things more specifically, and then urinary changes. We talked about frequency, flow, sensation, asking about things specifically. The sexual dysfunction that didn't get mentioned, right? Bowel and bladder doesn't cover that. But again, that's another thing. And people don't, we think that people don't want to talk about these things. But if they're in a medical office when they come to see us, and I have never had a patient, when it's presented to them, really look like they don't want to answer questions like that.
Yeah. And to be honest with you, I actually think I think it's getting better. I hope it's getting better. But even when I was in PT school, I remember some of my instructors, like, maybe perhaps like shying away from certain pelvic floor questions. Um and it was almost like this culture of, pelvic floor therapy does that, so we don't need to go there. And it's like, well, actually, those things matter a lot from a differential perspective. And maybe I'm not like a formal pelvic floor trained therapist, but I also need to understand what their symptoms are so that I can determine if something is more pelvic floor related or more abdominal or pelvic viscera related, or if it is truly, a symptom that could be coming from the spine or the spinal nerves, the cauda equina itself. So I hope that that's going away. I don't know. I would hope that it is. What do you guys think? Do we think our profession is getting better about asking about the perineal region?
I mean, I'd like to think that we collectively are as a profession. I know me personally, the longer I'm in the profession, the easier it is to talk about anything and everything. But it didn't happen day one out of school. And I don't know, looking back at my education, could they have done more to help that? PT school is overwhelming as it is. I'd like
Yeah,
to
true.
think that, yes, we can do a better job in school, in clinical rotations, in our continuing education classes to really lay it out there and talk about those hard things and provide a safe space for our patients to feel comfortable to talk about it. Looking back at the first few years of working as a PT, I was working for essentially a PT mill. I was seeing, 15 to 18 patients a day. We did not have private treatment rooms. And I got used to asking the question, have you had bowel or bladder changes? In that very generic way that Seth described, we learned in school. And people said no. So after, 300 times asking it, you do expect people to say, no, but I think it was the environment I was asking in, right? I was rushed, they were rushed, we weren't in a private treatment room. It was the way I was asking the question, very generally, not specifically, and maybe not giving off that confidence of like, let's actually talk about the specifics of it. Very different at this point in my career.
Yeah.
And I think that's what we need to set up our profession to be. One-on-one, private, at least evaluations where people have a safe space to really talk about it. And we have this opportunity to ask these very specific questions. So we're not just automatically breezing over things that we shouldn't.
Personal anecdote with that very briefly. So after I had my first FAI surgery, I had the really weird labrum on that one side. So I had a really long traction time. And for those that aren't familiar with FAI surgery, they have to put the hip on traction in order to so basically the operative side foot is in a boot. And then there's a perineal post that goes right up into your crotch. And then the boot sort of pulls the leg into a little bit of traction. I had a really long traction time because I had a really complicated case. And after the surgery, my crotch was numb. And it was numb for a long time. And when I went to my post-op PT, it was the same situation where it was just this, I was being evaluated in an open gym. There was literally somebody right next to me. And prior to this, I had never had a patient. I was kind of early in my career, or I hadn't done a lot of post-op. And I think that when I was thinking about like, I should probably ask her about this, but I didn't want to, you wouldn't think this, but when I'm working with other people that I don't know, I'm kind of a private person. I don't like to talk about that kind of stuff. And I just didn't even mention it. And I just ended up Googling it on my own. And that was something that I didn't even know about. And yes, the numbness came back, thank goodness. But like, that's scary for a lot of people. And I'm the number one advocate of like, please don't do your evaluations in an open space where there's 10 other people that can hear everything that you're about to say, because patients have private things to talk about. So yeah, there's that. Coming back to Cauda Equina.
Well, I think that's huge. Just as, you guys both said, I think building trust and, this atmosphere of safety in your clinics and around patients is just something that we need to talk more about. And I think as a profession, because it is in a lot of clinics, it's a weakness.
Well, and don't you think that like, because of that atmosphere, that sort of open gym setting, I know some patients actually really like it, especially for the social engagement, but for that very first interaction, don't you think we're missing things in that environment? Like missing things because we don't want to ask the questions or because patients don't want to answer. Like, don't you think we're like, that has to be a thing, right?
100%, no doubt.
Yeah. And I think maybe we don't look at it, we talked about it a little bit in, a recent paper that we had, Drawing the Perfect Circle, which was in JOSPT. We talked about maybe we could look at, that's another variable that you can control to a certain degree, is the physical environment in your clinic as a PT. So you can, even if you have one of those curtains in those big rooms that you can draw back, I mean, just helping it be a little bit more comfortable for them. And then, to your point there, if you're an athlete after your ACL repair, there's definitely probably a point where you feed off being in a more, open setting and the energy being there. But you look at it as a variable that you can control. Like, let's, take advantage of that energy today, or maybe they're having a rough day. They had a setback, something happened at home. Let's bring them in a room today. So you're thinking about that as something that you can help, customize to the patient on that particular day. I don't know that PTs think about that.
And it's something that I think that we absolutely should. I just think that contextual critical thinking is something that is lacking maybe across the board in healthcare. I do think that some people are thinking about it, but I think a lot of people are missing it just because that's like the culture and the type of environment that they were trained in. That's how everybody else around them practices. They've never had that modeled for them, and or they've never just had anybody bring it to their attention. So hopefully anybody who's listening to this will start thinking about that. Hold that thought. We will be right back. Just a quick break to share a few details on upcoming events at Redefine Health Education in 2024. We'll be back in Salt Lake City in January, 27th and 28th for our primary care PT hands-on workshop, where participants will get a chance to take a deeper dive into all the critical thinking and hands-on skills involved in a true multi-systems primary care PT assessment. You get a chance to practice things like heart and lung auscultation, use an otoscope to assess the ears along with vestibular complaints and head and neck pain, take an ABI with a Doppler device, and so much more. You can sign up online at our website, www.redefinehealthed.com. We're super excited for that. We also have a primary care and imaging showcase on April 24th, 2024, which will be live on Zoom. It's called a showcase because clinicians will literally show their cases. We're currently looking for some clinicians that want to take 15 minutes to present a primary care or imaging related case. You get to share your knowledge, hear other cases, and get some presentation experience. Or you can just sign up as a clinician to soak it all up. It's only $25 for 2 CEU contact hours. And a recording will be made available if you can't attend live. Thanks so much for your support, for listening to our podcast. And don't forget to hit that subscribe button, please. Thank you. It helps us so much. Share the word about our podcast with all your friends and pals and colleagues. And now we'll get back to the show. So coming back to Cauda Equina, if we have these patients where there are these, I love that term. I'm going to look at that paper, the grumbling Cauda Equina syndrome. What do we do? First of all, Seth, like what was we first of all, we know that this patient is not somebody we're going to send to the ED, because an ED visit, first of all, would not be fruitful. The ED physicians would probably be like, why are you here? Go home. Go see a neurosurgeon. I don't know. This patient has already had imaging done. And it seems he's fairly, the symptoms are intermittent. He's fairly independent. So what is your communication to the patient at this point, Seth?
Right. So yeah, as you've gone through this process, you're determining your level of concern with the patient, and then maybe you're deciding, all right, what's the action that I'm going to make with this patient? So if you decide you're going to go through and maybe use watchful waiting. So again, the context comes into play, but depending on the setting, you might decide watchful waiting is appropriate for this patient. It's been recommended in that red flag paper as the quote unquote best practice in face of uncertainty. So you're kind of waiting if you're not sure what's going to happen for the condition to become clear. I think with this guy, it's been 18 months. There's a mechanical presentation. Again, it's lower on the list. The other thing that you pair with that, if you're going to make that decision, is you have to help that patient understand their condition. So safety netting is a concept that comes from general practice, GPs, kind of, what are you going to do to help prepare the patient so they know what to look out for? And then they know what actions to take. So it consists of, making sure that they have the information on their condition. So they know what Cauda Equina syndrome is. They know what the red flags are, and there's advice on what to do for that specific person and where to seek help if red flags develop or things progress. And then they understand what that natural history is, what to look for, what the time scale is of this condition. So it might be something like, in this guy, hey, look, you can explain to him what the prognosis you think is. Look, you've had this. We called him Mr. May. We used a pseudonym in this case report. So, something like, Mr. May, we have these leg symptoms. They have a relatively mechanical presentation. You've had it for 18 months. I'm not overly concerned at this time, but, some of these, sensory changes that you're describing that come on, in the saddle area, make me, and the fact that you have symptoms in both legs, we're just going to have to watch that. One thing that can happen is symptoms can progress along this pathway where you might develop some of the initial symptoms might be changes in urinary function. So if I know you have BPH and you have this baseline right now, if things suddenly change, then what I want you to do is go to this, I know that you live in this older adult community. It's called Saddlebrook up the street, which I think is where he lived. So the nearest ER for you is over here.
That's a pun a little bit, but it's kind of an ironic pun. Does everybody get it?
The saddle. Yeah.
Yeah.
So, okay, you're going to go over to this ED. You're going to do this. You're going to explain to them, these are the symptoms that have happened. If you want, you can send me an email or give me a phone call if that happens. Mm-hmm. Again, not overly concerned, but I need you to, know that that's what one thing is that we're going to keep an eye on as we continue to treat you.
Mm-hmm. Great.
Was he concerned at all when you presented it that way?
Well, I actually don't think he was overly concerned. I think he did. Again, maybe not the average patient. I think he had an understanding when I mentioned it of maybe something clicked into his mind from back in medical school. And he was like, okay, so I know what to do. He had experience with healthcare. And so he had an understanding this is what he's going to have to look out for. And I think he trusted himself and he trusted me as time went on. And I don't think he was overly concerned in this situation, but I do think that's something that you have to look out for. Like, just as, but at the same time, they have to understand what the risks are so they can take action if things progress. It's particularly important if you're not going to see them for very long, right? So I'm aware that like in the NHS, it's really hard from what I've heard to schedule follow-ups with patients because they're so slammed. So you might not see a patient for a month. Mm-hmm. So that's when it's really important that safety netting is something that's a huge part of your practice. In the PT in the States, it's a setting where we see people more often. We tend to. So, I tend to see patients once a week, probably is the average. So I know that, hey, it's going to be a week before I see you. Things can change, but at least I'm going to see you next week.
Mm-hmm. Yeah, definitely. So I hope that people that are listening to this and just people that are trying to learn about this in general understand that every patient is different the way that you communicate with them. This patient was, highly educated, retired physician, who, again, Seth reiterated that, he kind of knows him. Seth garnered that this patient was self-aware, that he would be able to identify that. If you had a patient who was not in those circumstances, then you might treat that case a little bit differently. And you might want a little bit more, close touch points, or you might want to communicate that with another provider on the healthcare team. It just, again, everything just depends. It depends on the patient that's in front of you. You could get the exact same cookie cutter presentation with two patients and treat them completely differently. So we just have to respect that, that individualization of all aspects of care, from, obtaining, or should I say receiving a patient's history, all the way through the exam, and the way that we communicate with them and the way that we manage them. It's going to be individualized, regardless of what the presentation is. What else do I have here? So I wanted to ask you about, because I actually think this was a really critical part of the paper with the bilateral symptoms. The one thing that pops into my head is vascular presentation, especially with this person with this age range. So the fact that you took distal pulses was really, really important. So leg pulses on both sides checked out for this patient. So in this circumstance, what I'm doing, if I had a patient with this type of symptoms, I would definitely be taking those lower extremity pulses. And if the pulses were good, I would move on. If the pulses were questionable, especially if they were unilateral, to like, if there was a difference side to side, then I would be doing an ABI. That's me personally. What do you guys think?
I'm on board with that 100%.
Yeah, that's also kind of essentially what I do and how I think about it. The ABI things, like the little Doppler, I think they're not very expensive. I mean, they're like $100. Mm-hmm. So I think people should invest in those in their clinics. Concur,
because we do not like there. I have actually, when I was doing a clinical rotation at the VA, this was a million years ago, but when I was doing my clinical rotation there, I remember I had this one patient who came in with some peripheral arterial disease that was fairly advanced. And he came in, he was like, and at that point, when I was a student, I didn't know exactly what I was even supposed to be doing. I probably learned what an ABI was, but I had no idea what I was really doing. But ABI or peripheral arterial disease can actually progress really. It can be very subtle. You can have like an 80% arterial occlusion and still not have really strong symptoms. So imagine an artery that is 80% occluded and you're still not getting symptoms, and how quickly that could potentially progress to something that is really catastrophic. And in this particular case that I was referring to, this person initially came into the hospital. This was an acute care rotation. He came into the hospital with both limbs, both lower legs. And over the course of the time that I was there for my clinical, he had, a toe amputation, and then he had a BKA, and then he had an AKA. And it was a very, very rough situation. So I can't reiterate enough that if we are seeing patients with lower extremity symptoms like this, we are definitely also thinking about peripheral arterial disease. But if the pulses check out, like, move on. It's if the pulses are good and they're bounding all the way down, through the foot, I say don't, it's okay to move on and not do the ABI. Would you guys agree?
Yeah, I mean, it does take a little bit of time to do it. And so I think, yeah, I agree. I think that makes sense.
Yeah, it does. And takes me a minute. Like I teach the ABI in my courses, and Jess was actually there for my last Salt Lake City course. And there was this one girl, I just could not get her brachial artery, which like should be the easiest one because it's pretty big, but I don't know. It was hiding, and it does take time. All right, what else do we want to talk about with this? I think yeah, what else do we want to talk about? Anything? Are we
Well, I
done?
think it's important to follow up with how this patient ended up.
Yeah.
According to the paper, he's doing great. Is he still doing great, Seth?
Yeah. Yeah. I mean, the last time I talked to him, which was actually probably the follow-up after I saw him, yeah, was doing fine. So it's interesting. And we kind of have in table 2 in this case report, there's kind of this, level of concern bar that I put there. And I think I tried to do that to demonstrate that that's ongoing. So and on that first visit, maybe I marked it as a medium. You're safety netting him, you're watchful waiting, you're thinking, okay, I'm going to monitor these symptoms.
Mm-hmm.
Comes back and he's better. Comes back and he's even better again. And instead of walking 4 blocks, I think he's walking 6 blocks. Okay, now I'm kind of lowering that because so far he's responding to PT. He's not getting worse. In fact, he's getting better.
Mm-hmm.
So the level of concern is kind of dropping. And then he continues to get better and we discharge him after 8 sessions, I think. So, and then
this table, for anybody that hasn't seen it, this table is awesome. And this is exactly how, like, in my brain, as I'm seeing a patient from one visit to the next, especially if watchful waiting is on the table, this is exactly what your brain should be doing. And if something is there, truly, like if day 1, it's like a little iffy, but not enough to make your urgency so high level that you need to act within the next 24 to 48 hours, and you can wait a week, or you can wait, 3-4 days until you see the patient again. The next time that you see them, if you are checking that level of concern and it's gradually going up, like, things will declare themselves, right? Like if somebody has a spinal tumor, if they've got a spinal metastasis and you don't know that it's there, but it's one of those things that, like, they might sort of just get a little bit better with a little bit of movement, because again, movement, it just feels good to the immune system and everything. But if it's a spinal tumor and it's a growing cancer, it's going to declare itself. So over time, that bar will gradually go from medium to maybe medium high to maybe a little bit higher, because they're not going to get better. And you'll continue to see other features of that clinical presentation that lead you to believe that this is something that needs to be managed elsewhere. And then it's your role to decide what needs to happen next. So Seth, let's say this case, like, second visit was like probably about the same. Third visit was maybe with that flexion, you're not getting as much relief. And then fourth visit, maybe they're saying they're only walking like 3 blocks. Well, at that point, what would you do with this case?
If they're progressively worsening like that. Yeah. So I think, I mean, you kind of have to think about the setting that you're in as well. So it goes into the next step, which is, okay, you're going to make a decision I'm going to refer this patient.
Mm-hmm.
Then it's like, well, where are you going to refer them? How is it getting worse? What specific symptoms are getting worse? So if it's like his walking distance, and the leg symptoms were what were getting worse, and it was kind of slowly deteriorating, versus if it was like, all of a sudden he said he had rectal fullness or, something like that, where it's like, okay, well, then I would send him probably to the emergency department, knowing, we got to get some tests done on this. If it was just like what you might see with spinal stenosis, where, okay, his leg symptoms, he noticed he wasn't walking quite as far, the urgency again is like, well, I think I could probably call a neurosurgeon and talk to him about this guy and see if they could get him in, maybe in the next week. Right. So I think that so it depends on which symptoms, I think. And then you have to think about, how are you going to refer the patient? So if you do say, okay, wow, maybe I'm just going to go to the ED, you're in an area, that's where most of the testing can happen the most efficiently. So you're just going to say that. You can also, along with that, either prepare the patient. This is what I want you to explain when you show up in the ED, so it's not a waste. Or you could print something out for them, like, this is specifically what I want you to give the person. And it's a note from you to the staff in the ED. These are the things that I've found, right? So you're communicating that with them. Sometimes that gets missed, I think, talking to some of my colleagues in the emergency department, where somebody shows up and maybe they're not this gentleman with the knowledge level that he has. Maybe there's someone and they're like, well, I don't really know why I was sent to the emergency department. I think it's because my back hurts and I have these leg symptoms. And they might not know exactly what the provider was concerned about, or it might take some digging. So
yeah, definitely. That's exactly what I would do. And in that circumstance that I described, where it was a little bit more subtle, I would definitely try to see if I could get a neuro. This is why I always have like a solid network, my own sort of internal network of providers that I feel comfortable referring to, that are comfortable communicating with me, so that I can have somebody to at least bounce an idea off of, hey, do you think this would be appropriate? And if so, when do you think you could squeeze them in? Because sometimes you call the front desk, or a patient calls the front desk to make an appointment. They're like, oh, we've got nothing for 8 weeks. But if you talk to a provider directly, they can look at their schedule and be like, oh, I know this guy, that'll only take 15 minutes. So I can squeeze him in at that point. So I try to do that, and I would encourage everybody to also do that. But that might be even more fruitful than sending him to the ED if the symptoms are a little bit more subtle, and there is a much more slow progression. The emergency department is like the Wild West. I feel like healthcare in general right now is like the Wild West, but yeah. So I love everything that we talked about. I think that we covered a lot of really good things. And I know that Seth has, you've got a course coming up, right? Or,
yeah, if you're in the Baltimore area, we're doing a course on low back pain and leg pain. That's January 20th and 21st.
Oh,
so this
nice.
kind of pivots into that. We talk about all these things, and then use some case studies to kind of demonstrate and talk about these concepts, because they're tough. I mean, these patients are tough to manage, not just those with Cauda Equina syndrome, but just low back pain, leg pain in general.
Awesome. So you said January 20th and 21st?
Yep. And the Movement Brainery is the continuing education company. So it's
Awesome.
themovementbrainery.com. If you click on in person, you can sign up for that course.
Okay, cool. Then I'll try to get this episode out in December so that people know about that. Anything else we got to talk about? Any fun facts? Anybody doing anything cool for the holidays?
Well, I think, Katie, it's appropriate to mention the Salt Lake City course that's coming end of January in person as well. The Foundations for Primary Care.
I probably should plug my own courses too.
I mean, that's where it's easy to learn using the Doppler for ABI, among many other things that can be really relevant in this case and other cases where you're trying to figure out what's that urgency and what are we really doing with these patients? Are we treating them? Are we referring them? And if we're referring them, how are we referring them?
Yeah, that's the biggest thing that I think is a good takeaway from my course, or just any like clinical decision making, as when it comes to management. So once you've already determined your differential diagnosis, what are you going to do with it? Because not every case is going to be the same. Just like we're talking about in this episode, not every Cauda Equina needs to go to the emergency department. There's a spectrum of things that need to be considered before you make your decisions. And it's all going to depend on that individual that is right in front of you. So learning how to take all of those factors, tease them out, and then come up with a management strategy, and not just like, oh, I'm going to refer you to X. You're going to refer them so that for what result are you looking for? What outcomes? What tests are you recommending? What diagnostics are appropriate? And it is never okay to just quote unquote refer a patient. Refer for what? What's the outcome? What's the presentation? What are you hoping to garner? And are you seeing the patient back? There's lots of things that need to be, and actually I should plug another one of Seth's papers on referral decision making, because that paper was bomb, and everybody needs to read it. I'm just going to put all of Seth's papers in the show notes so that people can click on them. But yeah. So, okay. Thanks, guys. I feel like we could talk for a million years about a lot of other topics too. So if anybody wants to hear me and Jess and Seth talk about other clinical topics, you just email me and let me know. But we'll call it a day today. Anybody else have anything else they want to say?
Nope, I think this is great. I think it's
Okay.
very good to revisit what we're learning in school on paper versus what we're seeing in the clinic and what we're actually doing with people.
Totally.
Yeah. And I mean, it's important for people to know, early in your career, especially, to think about these things a little bit more deeply. And there's a solution. If you feel like you don't exactly know what to do, hopefully, if you listen to this and the links that you're going to post, you got some resources that'll help you figure it out.
Cool. Happy holidays, y'all.
You too.
And that's a wrap. Thanks for listening. If you love our show, go ahead and subscribe to stay tuned for future episodes. As a thank you to our listeners, we're happy to offer $50 off of our Primary Care PT Foundations course or our Musculoskeletal Imaging certification. Visit us at redefinehealthed.com and use code PCPTPodcast, all one word, all lowercase, on the checkout page to claim your discount. That's PCPTPodcast, all one word, all lowercase. Until the next episode, stay awesome, y'all.